Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with cardiac surgery? Find out more right now. My guest this evening is Dr. Kristens Shults, a cardiac surgeon at MedStar Washington Hospital Center. Chris, welcome to Housecall.
Thanks, David. It's great to be here. Thanks for having me.
My pleasure. So briefly tell our viewers about your professional background.
Sure. So as you mentioned, I'm a cardiac surgeon, which means I operate on the heart. I'm trained in cardiothoracic surgery, so could also operate on the lungs, but have focused for the last 9 years purely on the heart. My title here at MedStar is kind of threefold. I am the co-director of our complex aortic disease program. I am the director of surgical ablation, and I'm also the director of innovation. My practice, my focus, I have three, and I live at the intersection of cardiac surgery with interventional cardiology, vascular surgery, and electrophysiology. I focus on complex aortic disease, both open and endovascular treatment for aortic aneurysms, dissections, etc. I also focus on structural heart, which is valvular disease, so the valves inside the heart, and that I work with interventional cardiology, again, open, minimally invasive, and also transcatheter, which is something we'll, I'm sure, talk more about later. And lastly, I work with my electrophysiology colleagues in the ablation space, really focused on the type of atrial fibrillation that is not responsive to medical therapy or catheter ablation.
And tell our viewers about your training. How did you get to this point in your career? Where did you go to med school and do your training in your discipline?
Sure. Well, I opened the door, and 14 years later, I emerged from the training as a cardiac surgeon. I did undergrad in med school here at Georgetown, and then stayed in the MedStar DC system for general surgery. During that time, I went up to Boston and did a research fellowship at Massachusetts General for a year, and then did fellowship training at Emory down in Atlanta for 3 years, and then did some super specialty training 3 months at Arizona Heart, where I functioned as a vascular surgeon, 1 month in Leipzig, Germany, where I was benefiting from the fact that they were 2 or 3 years ahead of us in terms of what their regulatory agencies would allow them to do with catheters, et cetera. And then also spent 2 months at University of Houston working on complex aortic open thoracoabdominal. That's kind of the aorta as it moves into the chest and the abdomen.
Very distinguished background. So tell us about your MedStar team, so to speak.
Sure. I mean, it's a great team. We have at present 8 cardiac surgeons, and all of us are focused solely on cardiac surgery. We each have our, there are certain things that we all do, but there's also things that we uniquely do. We each kind of have our specific niche. Mine, as mentioned, is aortic, valvular, and Afib. We also have a robotic surgeon. We'll talk about that, I'm sure, later. We have an adult congenital surgeon who focuses on, a lot of patients are born with structural abnormalities in their heart. They have early surgery, and then as they grow older, they become adults and need adult congenital surgery to address those ongoing problems. We have a heart failure team focused on heart transplant and mechanical circulatory support for patients who are kind of at the end stage of heart failure. We have a couple of generalists, and we also have a couple others that are structural heart and kind of work in some of the areas that I work in as well.
Very distinguished menu, if you will, of services available.
Yeah, I mean, the important point is that, we have such a broad team and broad expertise. We really can cover anything that's needed, frankly.
Heart transplantation is part of the service that you provide. Where do we stand at this point with transplantation in terms of what you are transplanting?
Yeah, absolutely. So there's been a lot of innovation, and that's one of the things that attracted me to the field of cardiac surgery, is just the relentless innovation. There's always new things, new devices, new technologies, new techniques coming down the pathway. Heart transplantation has evolved tremendously, and that it's the absolute best thing you can do for a patient with advanced heart failure. The issue, obviously, is that the number of organs are limited. So there's a lot of progress being made on how can we expand the donor pool, and that includes kind of broadening the indications or the criteria for acceptable donation, even including now patients who've experienced have had a cardiac arrest and have effectively passed away. You can move quickly and procure that heart and also still transplant it. Another tremendous development is the mechanical circulatory support. So patients, as mentioned, not an organ is not always available. So in those cases, there's a lot we can do by implanting a pump, effectively a very small pump that sits at the apex, the very tip of the heart, that can take over for failing left ventricle and pump the blood necessary to keep a patient alive. And that can be as a bridge to transplant while they're waiting for an organ to become available, or it can be a destination treatment. So that would be their final pathway, and have had wonderful, tremendous success with that over time.
Where do we stand using other animal hearts, such as a pig heart?
Yeah, so we're all familiar with the ground-breaking transplant that took place up at the University of Maryland 4 or 5 months ago. That is a field that's evolving. That was a kind of the initial case, and like many innovations, it worked for a couple of weeks, but then the patient passed away. It was a product of new technology, new technique, but also a product of this patient was really knocking on death's door to begin with. So the fact that he survived 2 weeks is a phenomenal accomplishment. So I think you'll see more coming down that way. And obviously we learned a lot from that case, and innovation will continue.
Speaking of innovation, where do we stand with creating an artificial mechanical heart?
Yeah, so that innovation continues as well. There's been several models, and one of the trickiest things about a total mechanical heart is recreating the lining that lines the inside of a heart. One of the trickiest parts is preventing clots from forming, and the heart it's designed by God, or whomever you believe designed your heart. It did a pretty good job. It's a remarkable organ in its ability to not only pump millions of times, but also to prevent clots from forming. So that's one of the challenges in the different iterations of a total mechanical heart is preventing clot. There's several different pathways that have been taken, including 2 separate ventricular assist devices, one for the right, one for the left. But there's been a lot of development in the last few years with a total artificial heart. There's select centers throughout the country that really dedicated a lot of time and effort to building that. Some of the initial results are promising. It does mean you're tied to a machine that's larger than an LVAD, for example. And it's really primarily used as a bridge to transplant or something more definitive.
Is there any effort, given that you mentioned people have congestive heart failure, which means dead heart muscle in some cases, at least, if you've had a heart attack, is there any effort to infuse cells to restore and develop healthy myocardium?
Yeah, absolutely. There's a funny saying that stem cell therapy will always be the future.
Any success with it though?
There has been success. I mean, there has been demonstration of regeneration of myocytes. Again, it's not really mainstream. It's still kind of in the realm of research laboratories and research protocols. But there have been advances, and nothing really ready for prime time quite yet. But we're eternally optimistic, and I think one day that will bear fruit.
You mentioned earlier robotic surgery. So when is it appropriate to consider robotic surgery as opposed to something a bit more invasive?
Sure. So we, as you may know, launched our robotics program 3 months ago. The surgeon, Yuji Kawano, is Japanese. He came from Japan and then went to the Brigham for a few years and then down to Emory to spend 1.5 years with Doug Murphy. Doug Murphy is probably one of 5 of the most well-known and experienced robotic heart surgeons in the world. I spent 1.5 years with him and then joined us. And he has successfully launched a wonderful robotic heart surgery program. It's been live for about 3 months. He's done 21 cases, predominantly robotic mitral repairs and 1 or 2 replacements. And all patients have survived and done very well. No mortalities, and it's really very kind of taking a step back and looking at that 21 cases in 3 months of a fresh start program. Phenomenal, really just phenomenal start. But it's robotics is in several specialties really found niches. There was an initial foray into robotic surgery several years ago, but it's really found a place in mitral surgery, tricuspid surgery, removal of heart tumors such as myxomas, and then also for what's called hybrid revascularization, which is to use the robot to take down the mammary artery and sew that in through a small incision to the LAD, and then address the other lesions on the heart. The LAD is one of the 3 main arteries of the heart, and oftentimes patients have disease elsewhere. The robotic approach allows you to address the LAD, which is the most important artery, and then through stents, you're able to address the other lesions. That's why it's called a hybrid approach.
So do you think this will be viable to do a coronary artery bypass graft using robotic surgery?
Yeah, absolutely. So total revascularization via the robot, there are a handful of centers throughout the country who do that. We actually had tried that many, many years ago, not robotically, but kind of endoscopically, and found that it, like a lot of other centers have found, that it really just prolongs case times, doubles or triples the time. And it really, at the end of the day, wasn't worth it. But this approach, a hybrid approach, there's several centers. Emory, where I trained, had done, several hundred with great success. So there, for patients who are really most concerned about preserving, not having a sternotomy, interested in very minimally invasive techniques, which most patients are, frankly, it is a good option, and it's worth an evaluation.
There are, as you know, a lot of heart centers in the national capital area. What do you think makes your MedStar Center so unique and highly regarded?
That's a good question. I think there's 2 components to that. I think one is innovation, and the second is collaboration. MedStar has a long history of firsts in the capital region, in the Mid-Atlantic. Frankly, we were the first, one of the first three or four centers in the country to implant transcatheter valves in the aortic position. So a part of that Partner 1 trial, the very initial trial that Edwards ran to evaluate whether or not a transcatheter valve can be used to replace the aortic valve. Just last week, we implanted the first transcatheter mitral, the Apollo Intrepid. It's the Medtronic's Intrepid valve, the first one in the DMV, and that's similarly coming up through the artery, the vein in the groin. We come up and cross over into the left atrium, and then position the valve and deploy it into the mitral position. So that avoids a sternotomy, avoids going on pump, avoids arresting the heart. really phenomenal technology. And that was a very excellent result. The patient did very well.
I'm going to ask
we
you
were
to pause. I'm going
Yeah.
to ask you to pause there. We're going to have a public service announcement.
Okay.
More with my guest, Dr. Kristen Shults of the Washington Hospital Center. We'll be right back. We're back. My guest this evening is Dr. Kristen Shults, and we're discussing cardiac surgery at MedStar Washington Hospital Center. Chris, when we paused at the break, I asked the question, what makes the hospital center cardiac surgery program so unique? Share with our viewers some other examples.
Sure, absolutely. Thank you for the question. So I mentioned the valvular technologies. In other ways, we were unique. We were the first program and hospital system to engage in hybrid ablation, which has come to be known as the convergent procedure, which we started 11 years ago. And that's for patients who have an atrial fibrillation that's very difficult to treat, persistent, longstanding persistent. That's been a very successful program. We've done close to 400 patients now, and have kind of been leading the field both regionally and nationally as far as hybrid ablation goes. Another way, one other example is we have several endovascular technologies that we're using to treat aortic aneurysmal disease. We have a couple trials going now with
Explain to our viewers what is an aneurysm, Chris.
Sure. Yeah. So an aneurysm is it's a disease of the arteries of the body, primarily the aorta. The aorta is the largest artery in the body. It comes directly off the heart. Kind of think of it as the beltway. Compare arteries to roads. The aorta is the beltway, and all the other roads come off of it, basically. But it's the artery that sees the most pressure, the most pulsatility over time. So as you can imagine, over time, that aorta can dilate. And when it dilates to a certain extent, it's at risk for rupture. So based on the size and based on the size of your body, oftentimes we'll recommend replacing it, either open surgery or endovascular. Endovascular means that instead of opening up, we come in with the wire, we access one of the smaller arteries, for example, in the leg, and then pass the wire up into the main artery and then deploy a stent. A stent is it's a fabric with a metal, or kind of a metal-like structure that holds it in place. And it effectively seals off the aneurysm by sealing the aorta before and after the aneurysm. Yeah. So those are some of the examples of how MedStar as a system has been leading the field, not only regionally, but nationally, internationally. Also research. We're been very engaged in industry-supported trials, but also research of our own, looking at various aspects of cardiovascular disease.
Since you've brought up aortic aneurysms, these outpouchings from the aorta, explain to our viewers what is a dissecting aneurysm.
Yeah, so a dissection is an emergency. A dissection occurs when there's a tear. The normal aorta has 3 layers. And oftentimes, or sometimes, what can happen is that blood can tear in between the first and the third layer. And that when that pressure gets in between the layers, it dissects, it propagates down the aorta. That's very problematic because it can cut off as it dissects into a branch. It can cut off the flow to that branch, and that can occur to the brain, to the arteries to the heart, or the arteries to the legs, to the arms, or to the organs in your belly. It can also propagate in reverse and go down to the heart, and that can cause incompetence of your aortic valve, or it can rupture and bleed around your heart, and that can actually cause what's called tamponade, and that can kill you. So A dissection is a surgical emergency and needs to be treated right away. Fortunately, we have several helicopters that can bring patients in from all over the region to get acute surgical care right away. Because as mentioned, there's a 1% mortality. It's an emergency because there's a 1% mortality per hour. So for every hour that passes, there's a 1% chance you won't survive. So urgent emergent surgery is indicated, and it's bringing all the different technologies that we have to bear, both open and endovascular, to try to craft a solution for each individual patient.
Tell us about some of the collaboration you do with other teams at the hospital center, such as electrophysiology and vascular surgery.
Yeah, so that was my point number 2 on why MedStar is different. And frankly, it's one of the reasons I love working here, is because there is a high level of collaboration. As I mentioned initially, I work at the intersection of cardiac surgery with interventional cardiology, cardiac surgery with vascular surgery, cardiac surgery with electrophysiology. And a lot of these problems, we each have a different set of skills. So we recognized early on that kind of combining our abilities kind of lifts all boats. We're able to provide unique solutions because we each offer a different perspective and a different set of tools, so to speak. So it really allows us to kind of offer the best of the best that all fields have to offer for individual patients. In the interventional cardiology, cardiac surgery space, that translates into all these structural heart, these new transcatheter valves, whether they're delivered through the neck arteries, through the arm arteries, through the groin, the leg arteries, or through the veins. It's a very complex proposal to deliver a valve into the heart over a catheter, and we each have a different perspective. Interventional cardiologists have the interventional wire perspective. We have the structural. We understand the structure of the heart, how the valves interact, and what the heart will allow you to do. We would also, many of us have trained in interventional skills as well. So it's a very, very nice collaboration, allows us to kind of work very well together. The vascular surgery space, that's another area that, I mentioned I'm the co-director. The other co-director is a vascular surgeon, Javeria Fatima. She comes to us after having trained at the Cleveland Clinic and spent time in Florida. And she brings unique capabilities. She has an IDE, that means that she has been approved by the FDA to modify commercially available grafts, to cut holes in them to address a specific problem, which is an aneurysm in the belly. And that's something that's very unique to us at MedStar. And there are a lot of other trials. I mentioned a couple, they're FDA approved trials, meaning we're trying these new stent technologies in the aortic arch and in the thoracoabdominal aorta.
So our colleagues in oncology frequently have multidisciplinary meetings. An oncologist, a surgeon, radiation therapist, etc. And then they have so-called tumor board to discuss how they're going to approach optimally a patient's cancer. Do you have similar multidisciplinary boards that meet to discuss challenging cases before you embark upon a therapeutic protocol?
Yeah, absolutely. It's a great it's a great question. Every Thursday morning we meet as a valve team. So that's the cardiac surgeons, interventional cardiologists, echocardiographers, and CT imagers to review all of these structural heart cases, to look at all the options and make sure that what we deliver is the best option for the patient. On the vascular side, we have an aortic meeting every other week on Wednesday, where we discuss complex cases and again provide each of our individuals' perspectives. Then there's also a lot of informal kind of heart team meetings that occur between me and electrophysiology as we discuss hybrid ablation, and not only ablation for atrial fibrillation, but also we have a new trial for the ablation of inappropriate sinus tachycardia, ventricular fibrillation, et cetera. And then also, revascularization, how patients who have heart disease, which is the most common killer among men and women. How are we going to effectively restore blood flow to a heart that has blockages? And that, a lot of that happens informally. Just as patients come in, we meet, we talk, we discuss, we study, we get a litany of studies to really identify what the problem is and the best way to fix it. But that, beyond formal meetings, that kind of spirit of collaboration just continues informally as well.
Do you commonly scrub in together where you work side by side, or is it more one person is a predominant physician delivering one sort of discipline?
Yeah, so very, very commonly we scrub in together. All the transcatheter valves, that's both a cardiac surgeon and an interventional cardiologist working together. Likewise, for all these complex stents in the arch, in the belly, I'll scrub in with my colleagues in vascular surgery, and we'll do those together.
Who gets to choose the music?
That's a good question. It's funny. I actually let my surgical assistants often choose the music. But yeah.
As a gastroenterologist endoscopist, that's very important to me. So I was curious what my colleagues in cardiac surgery do. So what do you think are some of the future areas that are going to be very exciting in the next 5 or 10 years?
Sure. So, I mean, I think this movement, continual movement towards less invasive transcatheter will continue. I think, what has occurred in the aortic valve space has been revolutionary. I mean, it's just incredible. I mean, if you're coming in for an aortic valve replacement, as long as you're over 50 or 60 years old, is a very high probability that you're going to get a transcatheter valve, and you'll be home within 1 to 2 days.
And that's done through the groin.
Through the groin, yeah.
Yeah.
So that's been revolutionary, and that process will continue. The big targets now are the mitral valve, the tricuspid valve. Pulmonic valve has also been addressed for a long time in the congenital space, but there's new devices there as well. So that kind of innovation and trajectory will continue, and there's also potential for heart failure. Catheter delivered ventricular assist devices. We were also the first in the region just recently, my electrophysiology colleagues, to implant a dual chamber leadless pacemaker, meaning instead of having cables that tie your battery to the leads in the heart, there's no leads, so there are no attachments. So those little bullets of a pacemaker can just sit in the heart independent of leads, which is really great. I think that there'll be continuing improvements, and we talked a little about transplantation. There's exciting, using modified animal hearts, genetically modified hearts, stem cells. There's a lot coming down the pipeline. Likewise, in the vascular, the aortic space, this movement away from open surgery towards endovascular or stent technology continues. And we're seeing, all of the major companies, all the major players just continuing to broaden their pipeline and deliver new technologies, single branch, multi-branch devices to treat aortic aneurysms.
Chris, thank you for a wonderful interview. If our viewers have any questions, how can they reach you?
Sure. My email is christian.schultz@medstar.net. And our office number is 202-877-7464. And happy to field any questions.
Thank you for joining us at Housecall.
Thank you.
Thank you to the viewers for joining us this evening. Let us know how we can improve our show. You can reach me at my website listed below on the bottom of the screen. As for our next topic, it's going to be a complementary one to the one provided this evening. We'll be giving an update in thoracic surgery. It's going to be an important show. See you then next time on another edition of Housecall. Good evening.